Welcome and thank you for joining Cancer Support Community Atlanta for this program. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, and complete a new attendee form to stay connected to all future programs.
All right, so I think I will go ahead and get started. Welcome everyone to the Breast Cancer Imaging, the Basics and Beyond. I'm Emily Brown, the Program Director with Cancer Support Community Atlanta. If this is the first time you're participating in a Cancer Support Community program, we invite you to visit our website, cscatlanta.org, to see all the free oncology support services offered virtually, ranging from virtual support groups to monthly oncology nutrition seminars. If you miss a live event, you can find a recording on our website as well. I want to highlight that we do have a virtual breast cancer support group and advanced breast cancer support group that meets twice a month, as well as a virtual triple negative breast cancer support group that meets monthly. If you're interested in that, please check out our website, or you can email me directly, emily@cscatlanta.org, and I will be happy to add you to one of those groups. And all of our groups are led by licensed mental health professionals. And I want to go ahead and welcome today's program moderator, Dr. Karen Buhariwalla. Dr. Buhariwalla is a board-certified and fellowship-trained breast surgeon who specializes in the diagnosis and surgical treatment of breast cancer and all breast-related disorders. Dr. Buhariwalla is the medical director of the breast program at Northside Hospital, Cherokee. She received her medical degree from the Philadelphia College of Osteopathic Medicine and later completed her fellowship with Emory University in breast surgical oncology, receiving specialized training in the diagnosing and treating both benign and malignant diseases of the breast. Dr. Buhariwalla practices with Cherokee Breast Care, where she works alongside primary care physicians and other specialists to provide a comprehensive team-based approach to care. And with that, I welcome you, Dr. Buhariwalla, and go ahead and pass it off to you to introduce today's presenter.
Thank you, Emily. Can you hear me?
I can.
Okay, perfect. I appreciate that introduction. I have the pleasure of introducing Dr. Lynn Baxter. She is our board-certified radiologist and specialist in the field of breast imaging. She received her undergraduate degree from Duke University and her medical degree from University of Pennsylvania. Dr. Baxter completed her residency in radiology at Harvard's Beth Israel Hospital in Boston, and she went through additional training, or what we call fellowship training, in breast imaging at Emory University. Dr. Baxter has been the director of breast imaging for Northside Radiology Associates and the chair of the Breast Care Committee, which I'm part of, for Northside Hospital since 1998. She is passionate about educating healthcare providers and patients about the importance of early detection for breast cancer. So I know Emily touched on this a little bit. The side touches on where you can specifically go to look up Cancer Support Community's online programs right now. She touched on the support groups, stress reduction classes, nutrition seminars, education programs. If you go to cscatlanta.org, there's this awesome, I have the boring version, black and white, but if you go online, everything's color-coded. Stress reduction classes or groups are in blue, support groups are in red, education classes and groups are in black, and nutrition seminars are in green. Highly advise you guys to check this out. I mean, I'm looking at this stuff and I'm thinking, I want to do that. Gentle yoga, Tai Chi. I think you will find this is very, very useful information. So please check out the website if you can. Here's some additional screening information. Phone numbers and websites to reach where you want to find out more information for cancer screening programs, breast, colon, prostate cancer screening. Another website that'll link you to clinical trial information that we offer here at Northside Hospital Cancer Institute. And then if you need some more information on genetic counseling, we've provided that information there as well on the bottom part of the slide. So without any delay, we'll go ahead and have Dr. Baxter get started with her wonderful presentation.
Great, thank you so much. Thank you everybody so much for joining us today. I'm so happy to talk to you and answer any questions that you have. I could talk about this for the rest of the day because there's so many new and interesting things to talk about in terms of breast cancer imaging, but I'm going to try to go pretty quickly through just the basics and then some of the more recent topics of interest to people and leave as much time as possible for questions at the end, because I know cancer support community, you're a fairly knowledgeable group to begin with, and I don't want to review things you already know, but I want to focus on what's of interest to you. So real quickly, let's talk about the basics. And these are things you probably already know. You've probably all heard that 1 in 8 women will get breast cancer in the course of their lifetime. What a lot of people don't know, we all think of family history relating to breast cancer. About 3/4 of people, women who are going to get breast cancer, don't have a family history, and only 10% is related to the genetic mutations that we might be familiar with. Mammography, can't say this enough, mammography is the gold standard for early detection of breast cancer, and we know how important early detection is in terms of giving us more treatment options and trying to improve survival. Mammography is, despite the flashy new tests that we have and that I'm going to talk about, mammography is the only test of any kind that has ever been scientifically proven to save lives from breast cancer. So that's why it's so important. And that's why yearly mammography starting at age 40 is recommended for all women, regardless of family history. So beyond those basics, let's talk about some new technology and risk evaluation, breast density you might be hearing a good bit about these days, and then additional types of imaging in addition to mammography. First, let's talk about something called 3D mammography, or tomosynthesis is the scientific term for it. This is the latest and greatest type of mammogram that we have, state of the art. The reason we're so excited about this is that it addresses 2 of the biggest problems that we have with traditional 2D mammography. 2D mammography is excellent, the best test we have, but it does not find all cancers. Some of them are hidden for various reasons on the mammogram. And it also finds things that are not cancer that require us to call people back, take some additional pictures to try and sort it out and be sure that there really is nothing there. So the beauty of the 3D mammogram is that it finds more cancers, 30 to 40% more. This is in small studies, big international studies. I should step aside for 1 minute here to say that there is a large study going on in North America right now called the TMIST trial, which is a clinical trial comparing 2D and 3D mammography. We actually participate in that at Northside, out of our Alpharetta Northside location. So if anyone has any particular interest in that clinical trials information that Dr. Buhariwalla just showed you, that can help you to get in touch with someone who can let you know more about that. The other beautiful thing about the 3D mammogram is that it actually decreases the recall rate. You see 15 to 17% here in large studies. 15 is pretty much what you see across the board in these large studies. Some of the smaller studies even had that up to 40%. So this is really doing everything that we want a better mammogram to do. It's nice because it is so effective. It's been so effective in all of the studies that have been done that the insurance companies are recognizing this. It is becoming very widely available, and the insurance companies, most of them, are now actually covering it. Let me show you how a 3D mammogram works. So when we do a traditional 2D mammogram, here's the X-ray beam coming down through the breast onto the detector behind it. And anything that's along the course of that X-ray beam is going to end up at the same spot in the detector. So let's say you have, a big cyst or a patch of dense tissue up here, tiny little cancer down here. It's all going to end up at the same spot. You'll never see the cancer because it's blocked out by something in front of it. Same thing if you have a patch of dense tissue up here, a patch of dense tissue down here. They might end up at the same spot or right next to each other on the detector, making it look like there's something there when there really isn't. The beauty of the 3D mammogram is that it takes pictures from multiple different angles around the breast, and then the computer puts these together into a series of really thin slices that we can view as a movie when we look at it, and it shows us the internal structures of the breast, so we can see things that aren't blocked by things in front of or behind them. And I'm going to show you some examples of this. These are real actual patients that I've seen. This is a lady who had fairly dense breasts. She had cysts, fluid-filled cysts in her breast. We looked at it and said, oh no, is there maybe something kind of funny there? It's very, very hard to tell. We did a 3D mammogram, and I'm going to play the movie for you now. Watch as we go through. You can see how we're going in and out of the structures of the breast. You'll see those cysts popping out nicely. You'll see a little blood vessel down here that you can see beautifully with that. But I'm going to try to stop right there. You can see this is where we were questioning And look, there the tissue is all distorted. That actually is a cancer there. Totally unsuspected right next to it was another cancer, a second cancer in this patient that we would never have seen without the 3D imaging. And that lady had pretty dense breasts. This person does not have very dense breasts. She has a lot of fatty tissue in there. And this, I'll tell you, this case right here is the one that sold me on 3D mammography. I very much remember looking at this and saying, you know, hey, she's doing pretty well this year. I think things are going to be good. Went and looked at the 3D movie, which I'll show you now. Watch right in here where the marker is. See it right there? A little cancer that popped out that, again, was just hidden, even in breast tissue that's not very dense. And the 3D made a huge difference. So beyond that, though, let's talk about, so 3D mammograms, I think are terrific. I recommend them for everybody. They are useful for people no matter what the density of your breasts is, whether you have implants or not. They're good for everybody, and I strongly recommend them because we're finding additional breast cancers across the board. But let's say beyond mammograms, are there other things we need beyond that? There are some people who, in addition to the mammogram, need to have some other tests to help find cancers that might still be hidden. Even 3D is not perfect, and sometimes we need some additional ways to look at things. There are also people, we talk about the recommendation for the general public being started at age 40, but there are some people who may need to start screening before age 40. And this is all based on individual risk level. There is actually a relatively new recommendation from the American College of Radiology that all women should learn their risk level by age 30. This is especially important for Ashkenazi Jewish women, which is Eastern European Jewish heritage, who tend to have higher rates of having genetic mutations that make breast cancers more likely, and for African American women who also have a tendency to have higher rates of genetic mutations and who also unfortunately tend to higher rates of death from breast cancer and higher rates of some of the more aggressive breast cancers. The reason they're recommending this and urging this is if it is someone who is higher risk who needs to start getting their checkups before age 40, we need to know about that and have them starting to getting checked sooner. So that's why we want people to do it by age 30. There are a number of risk assessment models out there. This one, the Tyrer-Cuzick model, is very, very nice. That actually is very good at combining family history data with breast density and other risk factors. This one, the National Cancer Institute one online, is a pretty quick one to do. It's not quite as comprehensive as the other one. What I would recommend with this is definitely speak with your doctor about calculating your individual risk. Doing it with your doctor will allow you to put it in the context of your overall health and everything else that's going on with you, and then your doctor would be able to refer you if you needed, for example, to see a genetic counselor about maybe genetic testing, or if there are other specialists that you would need to consult with. So who actually needs additional screening? Well, the recommendations from American Cancer Society, American College of Radiology, pretty much everybody who's making recommendations on this are that if your risk calculated is 20% or greater over the course of your lifetime, yes, you're at high enough risk for getting a breast cancer that additional tests would be useful to help find those. Gray zone is 15 to 20%. If your risk is 15% or less, it is not recommended to have additional testing. And the reason for that is that, any additional tests that you get, none of these are perfect. None of them can completely distinguish 100% of cancers from 100% of things that are not cancers. There's overlap. So any additional test is going to have what we call false positives, which are things that show up on the test that are not cancer and can sometimes lead to additional tests or biopsies or things like that. And for lower risk people, it's much more likely that you're going to have that false alarm than that if something is seen that it might actually turn out to be a cancer. So who is in this group of 20% or greater? Well, people with the BRCA genetic mutations, and there are other genetic mutations, multiple additional mutations have been identified in the past few years that we know carry an increased risk for breast cancer. People who have had radiation therapy to their chest at a young age when the breast tissue is developing and is most sensitive to radiation. This is typically people with Hodgkin's disease or things like that. They are at significantly increased risk. These are new ones that have been added, which really is a lot of women, and I don't think a lot of women are aware of this. Anyone who has a personal history of breast cancer before age 50 is in that 20% risk group for having an additional cancer. And anyone who had breast cancer at any age but also has dense breast tissue, that knocks it up into that 20% risk. So that's a lot of people who it really is recommended to additional screening in addition to the mammogram. And then sometimes there are people who, just because of family history and other characteristics, based on some of those risk models that we talked about, end up being at that 20% level, even without a very, very strong family history. Who should start screening early? Well, people with the genetic mutations, because we know those people tend to get breast cancers earlier. Recommendation is to start MRI yearly beginning at age 25 and mammography yearly beginning somewhere between age 25, but certainly by age 30. The people who had the radiation therapy to the chest, that risk really kicks in about 8 years after the radiation therapy was completed. So 8 years after that, you'll want to start with the yearly MRI and mammogram, but not before the age of 25, because again, the breasts tend to be more sensitive to radiation at those younger ages. And then people, even necessarily without a genetic mutation, somebody who had a relative with a breast cancer at a young age, let's say mom had breast cancer at age 42, the recommendation would be to start with your yearly mammogram 10 years earlier than the age when you're relative. So in this case, start at age 32 if your mother was 42. What kind of test should you have if you need something in addition to a mammogram? The answer, number one answer, is MRI, and I'll show you in a minute. MRI has been shown in studies across the board to be the absolute best additional test for finding the most additional cancers. Ultrasound is something that we have that can find some additional cancers, but has an awful lot of those false positives and doesn't find nearly as many additional cancers as MRI. So that's something, if someone is high risk and for some reason, like brain aneurysm clips, or for some reason cannot have an MRI, that would be an alternative, but it's not the first line that we recommend. Thermography, absolutely not. No. And thermography is something, that unfortunately there are providers, companies out there that run thermography centers that try to market this as a holistic alternative to mammography, which is really deceptive. And the FDA is really trying to clamp down on these people and shut them down. Thermography, while not illegal, it is not legal to say it is an alternative to mammography or to do it instead of a mammogram. It is scientifically, it just doesn't provide any useful information. If you have one and it doesn't show a breast cancer, well, that doesn't mean you don't have a breast cancer, and they still have to tell you to get a mammogram. So you've paid them for this test that gave you no useful information, still need to get a mammogram. Same thing, if it shows something, it's going to get you all stressed out that you might have something, doesn't mean anything. They still have to tell you to get a mammogram. They've still taken your money. Just not a useful test. Here, this is from a big national study that was conducted in this country, which initially was started to look at ultrasound as a supplemental test to mammogram in higher risk patients to see if that could find additional breast cancers. But as we learned more about MRI as the test went on, they added MRI as well as a third part of the study. And you'll see ultrasound did find a few more cancers than mammogram did. We know it can find some for sure, but when they added the MRI, it just blew everybody away. MRI found so many more cancers than the ultrasound ever did. And what they found was that the sweet spot, the absolute best combination for finding the most cancers, was the combination of mammography and MRI, because there were some that showed up on mammography that did not show up on MRI. The same thing, some on MRI that were not on mammogram. What if we put all three together? Wouldn't it be best to do all three? Actually, no, they looked at that. Adding the ultrasound to that combination of mammography and MRI did not add any additional cancers, and it added a whole lot of additional false positives. So the recommendation for people who are higher risk is to do mammogram and MRI every year. What about dense breasts? We hear a good bit about that recently. And I can tell you a little bit about that and how that fits into our pattern as well. Let me back up and tell you, what is breast density? What are we talking about when we talk about I have dense breasts? Well, we're talking here about the amount of fibroglandular tissue in the breast versus fatty tissue. So basically, anything that is not fat that is in the breast will look white on a mammogram, as opposed to fat will look dark gray. So it's anything that's not fat, which is usually fibroglandular tissue, glands, and that sort of thing. Breast density is something that's really variable. There are a lot of things that can make our breasts look more or less dense. Some of it is just what we're born with. Some of it is other things that we can do, such as if we're taking hormones or not. And it can certainly change over time for an individual. You can't predict breast density just by looking at someone. You can't find it on physical exam. There are people whose breasts feel very firm, but it's really fatty when you look on a mammogram. This is something that can only be determined by imaging, most usually a mammogram. Most states actually now have laws that require when we send you your results letter for your mammogram that we include a paragraph talking about breast density. And this is something in Georgia, we've had it for a little more than a year now where that's been required as a part of the notification. And it's something that people are getting this and getting stressed out and thinking, oh my goodness, do I have a breast cancer? Is there something hiding? And it's something that hopefully we can put into some context for you and answer questions about, and hopefully your physicians are becoming aware of it and able to put it in context in terms of what this means. Definitely do not panic if you're told you have dense breast tissue. In terms of breast density, this is what we see when we see on a mammogram. There are 4 different categories that we divide the density of the breast into. And you can see on the extremes here, this is a fatty breast. You see it's mostly dark gray. This is what we call extremely dense, where it's mostly white, so mostly things in there other than fat. And then there's the 2 in-between categories. And this looks nice and neat divided into 4 categories, but it is really not that way in real life. It's pretty easy to distinguish between these 2 extremes, but it's only about 10% of people who are in either of these 2 end categories. It's about 40% here, about 40% here. And there's a lot of overlap between these 2 middle categories. You can imagine if this person here had just a little bit more dense tissue back here, would she look like that? Would she be called dense? Would she be called scattered? They've done studies, and if you have 2 different radiologists look at the same patient who's in one of these in-between groups, one of them might call it dense, one might call it scattered. Same radiologist on different days might call it one thing, one or another. So it's definitely a continuum and not something to think it's so rigid and, oh my gosh, the minute I cross the line between these 2 categories are considered fatty and these 2 categories are considered dense. So the minute you cross the line between this doesn't automatically increase your risk a lot or make things much, much harder to see. It's definitely a continuum. Why do we care about dense breasts? Well, there are 2 main reasons. One of them is that it can hide breast cancers. Going back and looking at this, remember we talked about anything that's not fat looks white on a mammogram. So you can imagine if a cancer that's white starts to grow in a breast that's mostly dark gray on the mammogram, it'll be easier to see than a cancer that's white starting to grow within a background of white in breast tissue that's more dense. Doesn't mean we can't see them. We do see most of them on these other breasts, but it's harder to see, and some of them actually are hidden. The other thing that's interesting is that having dense breast tissue actually has been found to increase risk of breast cancer, independent of family history or hormone use or things like that. It seems to, for some reason, just on its own, dense breast tissue seems to increase that risk. And there's a lot of research going on to figure out why that is. It's not a huge increase in risk. It's small, 1.2 to 2% greater than the average person. And to put that into perspective, people who had their first child after age 30 are about 4 times increased risk. So it's not a big risk factor. Don't think, oh my gosh, my breast tissue is dense. It's really increased my risk a lot. The other thing is dense breasts alone do not put anybody into that 20% category where just because of dense breasts would be recommended to automatically have an MRI. It's something that you take into consideration in terms of the rest of the risk factors that you have, and again, identifying your individual level of risk. One thing that I will mention here, especially because we're talking about new technology, is something called fast MRI. And this is something that was developed particularly for people with dense breasts because we know, as we just saw, that MRI is a much, much, much better test than ultrasound in terms of finding additional cancers. But MRI, traditionally has been a long test, an expensive test, something that was not covered by insurance for people who weren't at high risk. And for people who had dense breasts, if they really wanted some type of additional screening, ultrasound was what was done. And that just wasn't finding as many cancers and was giving a lot of false positives. So fast MRI is something that has been developed that fast is really fast. It's about 15 minutes. It does not have as many sequences as the full MRI. It's not as complicated in terms of its analysis. But the studies to date have shown that as a quick additional screening test, it is similar to full MRI in terms of how effective it is. So this is a nice option that is available. We have it here at Northside at a number of our facilities. It's starting to catch on around the country. There is another one of the big clinical trials that is currently going on, and the preliminary results have been excellent in terms of fast MRI, finding additional cancers in people. So that's something for people who, who may not need a full MRI based on risk, but have dense tissue and are looking just for a little additional supplemental screening. That's about all I have. I do want to reemphasize the basics before we go. Mammography, absolutely for everybody, saves lives for all breast densities and all risk levels. Any additional tests should be done in addition to supplement the mammogram, not instead of the mammogram. And I do have in here a flyer, which we probably can have someplace else on, we can put up somewhere. We do, through Northside, have a program for uninsured patients, lower income patients who need mammograms, who need screenings, and there are ways that we can help to cover that and provide that through our facilities. Okay, so I'm gonna turn back over to Dr. Buhariwalla, and hopefully we can answer some of your questions.
Thanks, Dr. Baxter. That was amazing. We do have a lot of questions coming in, and I hope we can get to everyone's questions today. One of the questions that just came in was, how long after finishing breast cancer treatment, and this is, I guess, someone who has gone through or considered chemo and radiation, should you have diagnostic mammograms before going back to regular mammograms? So I do my little spiel in the office once we've done their surgery, and I give them a nice little umbrella understanding of how surveillance is going to work moving forward. Of course, there's all these different guidelines out there. There's the National Cancer Guidelines, the ACR guidelines, and I usually try to stay in line with what you guys recommend, because I find that that's what works best. But you can chime in and let me know, but I usually tell them there's that quick surveillance period within that first 2 years of treatment. And in addition to seeing me every 6 months for an exam, especially if they went through breast conservation or lumpectomy, anticipate going through close diagnostic mammograms of that affected breasts. But you can elaborate if you'd like on that question a little bit.
No, and that's a good question. And there is there's no specific scientific answer for that. There are no specific recommendations from American College of Radiology or American Cancer Society with that. So there is some variability among providers, but just as you do, that's what we typically recommend, that close surveillance with diagnostic evaluation for the first 2 years after breast surgery. And that's because in those 2 years, that's when, after that, things start to settle down a little bit in terms of, the scar tissue and changes from radiation potentially, getting to basically what is the new normal for your body. And so we'll follow closely to be sure that there's nothing that pops up as suspicious during that time.
Beautiful. Has it already become gold standard, or it's 3D mammography?
I don't think we can call it the gold standard at this point. Maybe after the TMIS trial is finished, we'll say for sure it's the gold standard, but it's, all of the, and this is one of the things that, when do you say, how do you determine that something is the gold standard? I mean, we know mammography is, because that was, hundreds of thousands of people in those studies over many years in many countries. I have not seen any test, small, large, of any kind, that did not show 3D to be better than 2D. And the nice thing about it is, some of the other technologies, you say, yes, it can find more cancers, but does it have more false alarms? So you have to weigh the benefits, the false positives, the false negatives, all of that sort of thing. I'm not really seeing a big downside to the 3D, because it's finding more cancers, it's decreasing the false positives. The other thing about it, when 3D first came out, one negative about it was that we had to do the regular 2D mammogram plus the 3D component of it, and that was more radiation than if you just had a single 2D mammogram. But now, with the latest versions of the 3D equipment, which actually I should say, for those of you who get your care at Northside, in the past 6 months or so, we have replaced every machine in our entire system with the upgraded latest version of the 3D mammography, where we are able to recreate a 2D image from the 3D data that we have. So it's just one set of pictures that's taken. It doesn't have that increased radiation that it had before. So it's high definition. We're seeing things even better. And that kind of took away the one downside of 3D. So I don't see a whole lot of reason not to get it. Presumably your insurance covers it.
Talking about, I get a lot of patients who come in, and I try to explain the 2D versus the 3D aspect and the benefits. When they come and walk into breast imaging, a lot of patients tell me, well, nobody really specified on my order. Does somebody in breast imaging approach the patient about considering 3D, or it just relies upon their insurance? How does that process work out exactly?
No, it does. And a couple good points you raised there. We don't need a specific different order that says 3D on it. Some physicians will write that on the order, but you don't have to have that. A regular order that says screening mammogram is fine, or diagnostic mammogram. Yes, when people come in, the technologist will let them know if it's somebody who hasn't had one before or wasn't aware of it before. They'll let them know what's involved with it. They have specific information with the actual codes for insurance, so that if somebody wants to call their insurance and check, they'll have that information available to them. And it's because it's not something that's covered by every insurance company now. It's not something that we want to just go ahead and do for everybody when they come in and completely replace that option of having the 2D mammogram there. But it's pretty, I saw some data, I don't know, within the past 6 months or so, that it's 90% plus of the insurance companies in Georgia do cover it. So that's
right.
something, if people are aware of it, they may want to check ahead of time as well, to save time on the day of their appointment.
Valuable information. I guess there's kind of a recovery question. An individual that may have gone through breast conservation surgery or a lumpectomy and wanting to know the recovery period. And I can touch on that a little bit. That completely relies upon the type of lumpectomy you've had. If you had a reduction done at the same time, or how large was the resection, were there lymph nodes that required removal. I think that's an individualized answer, but typically the recovery is a lot quicker than if somebody went through a mastectomy. A lot of times patients are going home, and I'm talking from the perspective of a person who's been diagnosed with breast cancer. And they go through lumpectomy and removal of some lymph nodes. Some patients can go through lumpectomy for non-cancerous lesions. But generally speaking, you can go home the same day. It's usually outpatient surgery. You're not requiring too many drains, not too many cuts, usually some surgical glue or some steri strips, and then you're back to yourself within 24 to 48 hours. The recovery from a mastectomy takes quite a bit longer. I usually tell patients anticipate a month where, your homeostatic mechanism is off a little bit. But, the follow-up to that regarding percentage of cases for spreading it further, that's also an individualized answer, requiring your specifics to your pathology. What's your final stage? Were your margins good? Were there lymph nodes involved? And then most particularly, and we can segue into this a little later, what's exactly feeding your cancer cells? Was it your hormones? Was it a growth factor or protein called HER2? Or was it one of the more aggressive subtypes that we call triple negative breast cancer? So a lot of things factor into that question. I will tell a lot of my patients when they come in, they've had this imaging and they've been biopsied, it shows cancer. When I discuss with all my patients their surgical options, if they're allowed to have both these options, I will discuss it with them to go through either lumpectomy or mastectomy, and to understand that survival is not different between either procedure, so as long as they undergo radiation when they're going through breast conservation surgery. Another individual asked, I think this is a good question, Dr. Baxter. Some of our patients, when they go through surgery, they develop seromas or scar tissue, fluid pockets, and generally I tell them, if I can aspirate it, I'll do it, kind of segue into radiation therapy without a fluid pocket. But sometimes they develop during radiation, and then nobody really wants to stick a needle or drain or take them to surgery right when they're going through that process. And I lament it, but I tell them a lot of times this can be chronic, but slowly will be absorbed, But I think the concern is patients don't want to go through the paddle, don't want to go through the mammography when they're in that 2-year surveillance program right after their cancer surgery, and they want to say, can I have ultrasound instead? I usually tell them I would advocate for the mammogram because there are a lot of things that can be missed on ultrasound, such as calcium deposits, that can be concerning. If you wanted to touch on that a little bit too.
No, absolutely, that's right. And the mammogram is really important because one of the earliest signs of breast cancer that we can see are tiny, tiny little calcium deposits in the breast. And that is something that will not show up on ultrasound, will not show up on MRI. These are the cancers that get found with mammography that aren't found with anything else. And oftentimes those are the earliest signs of a recurrence we can see, the earliest signs of new cancer that we can see. So if at all possible, it's really important to do the mammogram. I would not advocate an ultrasound instead of a mammogram. One thing I would say is, get your mammogram. First of all, the other side is important to check as well when you have your mammogram. But also, talk to the technologist and work with them, and they can sometimes compress not as much as they normally would and not necessarily get the perfect picture, but at least give us some means of looking at it. If you absolutely cannot have a mammogram and need to have something else, MRI is the way to go instead of ultrasound.
I'm sorry, I'm trying to stay on top of this. Let's see here. We have another question. If I don't have family history of breast cancer, is it still important? This is very important. Is it still important that I schedule a mammogram during COVID-19? I will say, and I know you will, we have to keep in mind that cancer doesn't stop even during a pandemic. And so, the whole purpose, as Dr. Baxter has talked about, the purpose of these screening mammograms is early detection. I mean, you can attest to this, but, since the 1980s, we have had a 20% or more breast cancer death reduction, since the advent of mammography. And so earlier detection is key so that the survival is better. So, you're more likely to die from a later, more advanced staged breast cancer than COVID.
And that's, it's something that the National Cancer Institute recently published a statistical analysis on it. And unfortunately, they are predicting that in the next 2 years, we're going to see about 36,000 delayed breast cancer diagnoses. And unfortunately, over the next 10 years, they're predicting about 10,000 people are going to die of breast and other cancers that they would not normally have died from because of delayed diagnosis and delayed treatments. So I would say unless somebody has really, really serious other health concerns that would prevent them from going out, definitely you don't want to delay your screening. And it's, you mentioned the family history. We talked about at the beginning, about 75% of people who get breast cancer don't have a family history. So that's why it's important for all of us to get our checkups.
Thank you. We have another question. I had a lumpectomy for DCIS, and my primary care doctor has been doing, chest x-rays for surveillance exams annually for years. I learned from other friends who have possibly been diagnosed with this that they don't have chest x-rays every year. Any thoughts? So, I don't know if the ACR has any recommendations, but I follow the National Cancer Guidelines, and unless you are someone who is being followed by an oncologist or a breast surgical oncologist, with your routine checkups, and it was determined that, now you're having new symptoms, like it's a cough, and you're someone who has been diagnosed with breast cancer in the past, we have data now that shows we don't need to be routinely doing these CAT scans or chest x-rays or bone scans, have you, like we used to, like it was part of the guidelines in the past. We don't routinely order these unless you are symptomatic and we're concerned about a recurrence.
Yeah, I agree completely.
We have another one. This is a good one. Do you see a lot of gynecomastia on male patients?
What's a lot of gynecomastia? I'd say most men that I see have gynecomastia, but I probably don't see most men. So I don't know, honestly, percentage-wise how prevalent gynecomastia is out there, but it's we definitely want to encourage men who feel a lump to get checked out because 1% of breast cancers will occur in men. And even though stage for stage, the treatments are the same and the survival rates are the same, men, unfortunately, are typically diagnosed much later than women because they're not getting screened. They shouldn't be screened, but they're not getting screened. And when they feel something, they're kind of embarrassed to come in and get it checked out.
All my male patients probably get mad at me, but they appreciate it at the end of the day. But yeah, I have a question. As a male with 3 to 4 weeks of soreness under the areola and the nipple, the areola is the brown area that surrounds our nipple. How concerned should one be? There is no redness or other indicators of infection, lumps, etc. You know, as you know, all of us have female and male hormones. Men do, women do, just men have a little bit more of the male hormone and the women have a little bit more of the female hormone, so vice versa. And so as we age, sometimes it can be a physiologic thing, where you got a little flux in our hormone levels as a man, sorry. And so whether it's taking a new medication, if you're an alcoholic, loves to binge drink, or if you're taking some form of hormone that could be altering your baseline testosterone levels, you know, a lot of medicines out there can, you know, the side effect can be, you know, male breast glandular enlargement. And a lot of times, you know, the presentation will be, I feel a lump and it's tender or it's sore. My job is essentially, if I can see it, feel it, I'll do an ultrasound, or a lot of times just for clarification, I will send the patient for mammography, especially if there's a family history of anything. But a lot of this is reassurance. It is an endocrine problem. If we can rule out this is not a serious issue like cancer or something that's atypical that may need surgery, then reassurance is provided. You can have a close follow-up, but a lot of times an endocrinologist may need to feed into this process to provide, you know, some physiologic adjustments of the hormones. And a lot of times symptoms can resolve. I'm a 10-year breast cancer survivor. Congratulations. Stage 1 and margins were clear and my lymph nodes were clear, but I was triple negative. And as we know, triple negative breast cancer, we have the 3 big subtypes. We have the estrogen positive, progesterone positive. We have the HER2 positive, which is a growth factor or protein, or we have the triple negative breast cancer. And the question is, should I be doing any additional screening? And she is 10 years out. I don't really, I'm assuming well, we can look at it from a mastectomy or a lumpectomy standpoint. I'll go ahead and answer if you have any feedback on that.
So, well, I guess part of that question is how old were you when you had your breast cancer? And presuming you had a lumpectomy as opposed to a mastectomy, how dense are your breasts? Because that's, if you still have even one remaining breast, and your cancer was before you were age 50, or if even if it was after 50 and you have one remaining breast that is dense, then the American College of Radiology recommendations would be to do an MRI in addition to mammogram yearly.
Correct. There is no, I guess if our participant was worried about, well, you answered it. The difference between screening and diagnostic mammography, Dr. Baxter, I think you already touched on that. And then another person is asking, do the Northside vans offer 3D mammograms? And I don't know the answer to that question.
Yes, yeah. All of our machines, we have the brand new state-of-the-art high definition 3D machines on everything, including the van.
And then I think she already provided that information from the breast screening.
And the Breast Care Fund screening assistance covers that as well. That covers three.
I have been diagnosed with breast cancer. My surgeon wants an MRI. What is the role of MRI in treating breast cancer? From my perspective, a lot of things factor into this question because, you know, I will look at age, I will look at the density of your breasts. I will note, you know, is this a cancer that has multiple spots in one part of the area of the breast, or there's more than one part of the breast that has breast cancer? And I want to make sure I have a clear understanding of the true, what we call extent of disease in that breast, which helps me as a technician at the end of the day figure out my surgical planning. A lot of times, 5 to 8% of the time, especially if I feel something in the opposite breast, it can help detect additional cancer. And then it can also give us a clear picture what's going on with the lymph nodes as well.
And that's, yeah, I agree with everything you said there. It's a lot of times surgeons will recommend that as part of their surgical planning, because if there is anything else hidden anywhere in that same breast or hidden anywhere in the other breast, you kind of want to get everything treated all at once. You don't want to treat the cancer you know about and then next year say, oh, wait, here's another one, let's go back and do it again. So a lot of surgeons will do it for that particular reason. And there are some types of cancers, you know, there's one particular type of cancer called lobular cancer, which is very, very, very difficult to see on a mammogram, a physical exam. That's the one that's scares me half to death, all the time, because it's just so subtle the way it develops. It kind of spreads out through the tissue, single cell at a time, instead of really forming a lump. Those show up very nicely most of the time on MRI. So if you're diagnosed with that type of cancer, I would say most surgeons would want an MRI before surgery.
Now, with these fast MRIs, I know we're switching subjects. Are you advocating for these women who just have dense breasts, no family history whatsoever, nothing that's altering their risk, like their own hormones, anything, just dense breasts? Are you advocating for them to go through that as supplemental screening to their annual mammograms annually as well, just like we would for any other individual?
It is not something that across the board we're saying. For people who are lower risk, people who are in at 15% or lower risk, don't have any other risk factors, it's not specifically recommended to have any additional screening, because as we talked about, the chance of having a false positive, a false alarm from the additional test, including the fast MRI, probably outweighs the chances of finding an additional cancer in the lower risk people. But, having said that, it's an individual patient situation, and peace of mind is very important. And there are patients that I work with, and I bet patients that you work with, who say, if there's any chance that something is hidden, I don't really care if I have to have additional tests or additional biopsy. I really want to have that peace of mind of knowing that I did everything I possibly could. So if it's somebody where that peace of mind is going to be more important than, the possibility of having to have additional tests, then I think a fast MRI is a nice alternative to ultrasound, because it's going to find more cancers, and to full MRI because it's faster, it's cheaper. It's not fast MRI is not something that is covered by insurance. For higher risk patients, we recommend the full MRI, and that typically is covered by insurance if you're high enough risk. The fast MRI is a self-pay exam. It's, as I said, it's a quick supplement to the mammogram for those people who are not high risk but are looking for that little bit of reassurance.
I know everyone's hearing us talk about high risk a lot. I think the key is always, to take away from this is, know your history, talk to your mom, talk to your dad. I know I get a lot of patients who are like, we're estranged, we don't know much on that side of the family or whatever information you can get. I mean, you and your siblings, and then if you do know somebody is tested positive for a gene mutation that, hereditary risk for breast cancer is elevated, then you probably need to speak with a breast surgeon, or start with your primary care doctor or your internal medicine doctor. Get that conversation started. The only way you're going to know this information is if you ask and be your biggest advocate. I think we have I'm sorry?
I was going to say, and there are other risk factors too that play into these risk models, particularly the Tyrer-Cuzick, which is, the more thorough risk model. It talks about how old were you when you had your first period? How old were you when you had your first child? How many children have you had? All of those things play into risk. And that's what's really nice about some of these models is it puts all of that together. And I'm actually very surprised. I'll do them sometimes with patients who are here in the office, and people who we thought would be, surely they're going to be very high risk. They aren't for whatever reason. And it gives them a lot of peace of mind saying, oh, okay, good. I was more worried than I should be. And other people who have just a combination of small risk factors that adds up to be a bigger lifetime risk than you would have expected.
And I always remind everyone that when I calculate this risk, it's a population-based risk calculator. That number doesn't stick with you for the rest of your life. I always tell them every couple or 3 years, I recalculate that risk. So maybe we find your density changes, because density does factor into that risk calculator. Just like you said, a hormone replacement therapy is if you had your female organs removed, how old were you when that, a lot factors into that. And so even if your density of your breast changed, maybe in 2-3 years, that may lower your risk. So this number, this statistic we throw at you, it's not something that carries through with you for the rest of your life. It does ultimately lower where you probably can go back to screening mammograms.
No, that's right too. And also I've noticed with people, even people who might have been higher risk when they were younger, the longer you live without getting breast cancer, it tends to decrease your calculated risk, because, you've made it, and whatever it was that was going to cause it in you hasn't caused it yet, and hopefully will never cause it.
And I think that segues into this individual's question, how long do you recommend someone with history of breast cancer have breast MRI? I think that's this is like precision medicine, it's an individualized risk calculation. I mean, again, if your density seems to become fatty replaced, we may have a discussion about that. Is there utility moving? Would you agree, Dr. Baxter, if this is an individual who's had breast cancer in the past, maybe they were diagnosed under the age of 50 and now we're implementing this protocol? Well, maybe we need to do, high risk for cancer detection purposes with supplemental MRI. It may not be the case, and we just have to adjust your risk accordingly.
It's true, and that's a really complicated question, and part of the answer is that we don't know exactly yet. There is no specific cutoff. I think it's something that you need to individually think about and talk with your providers about, because MRI hasn't been around long enough to have those long-term studies of seeing how long do we need to do this screening. The other thing is a lot of the risk models don't apply to people who have already had breast cancer, in terms of how likely you are to get another one. A lot of those are for, getting a first-time breast cancer. There's a lot of times I'll see people at the breast meetings will talk about us, and they'll say maybe age 70 or something like that might be a time to think about cutting back on doing it, but it's nothing specific.
And fast MRI needs contrast.
Yes, MRI. You can't do breast MRI without contrast unless you're looking. The only type of breast MRI you can do without contrast is to look at silicone implants to see if they are ruptured or not. But if you're looking for cancer, you have to have contrast. And the reason for that is, the reason that MRI is so beneficial to us as a supplement to the mammogram is that it looks at blood flow patterns in addition to just anatomy. And that's how we see the blood flow patterns, is with the contrast. And that gives us a huge amount of additional information, physiologic information.
This is a good question. I've heard that the contrast, and this was a topic of discussion that came in the news, 2016, that the contrast that's given for these MRI scans can affect the brain. Mm-hmm. So, and I think this relates to different companies that produce this particular type of contrast, and we've determined in the U.S., or particularly I know at Northside, we don't utilize that product. The Gadavis product, because we know certain molecules don't leach out of that and go into our brain.
Right, and it is something that we always want to be very careful about. And they did find certain types of the intravenous contrast from the MRI depositing in the brain, and they've just noticed this. They found it there. They've not seen any problem that it's causing there, but it's certainly something that that we want to be aware of. And so when that came out, we did switch to a different type of contrast that we're using that has not been shown to be depositing in the brain.
We have patients who state, I'm a 10-year survivor. My specialist did an ultrasound on my breast near the lumpectomy site. And that could be for whatever reason. That could just be, we want to monitor an area, the scar, we just want to make sure it's not changing, or there's a concerning area that we just want to follow and make sure it doesn't need to be rebiopsied. I guess an individual was asking, the ultrasound was only performed on the self-reported area, not the entire breast. I'm not entirely sure why it was. Maybe she was reporting a lump, or the surgeon or the specialist was just following the scar. By not doing the entire breast, a whole breast ultrasound, would we be missing something? And it's hard to answer that question because we don't know the reasoning for why they did this. I will say that it's not standard to be ultrasounding the entire breast. A lot of times the ultrasound is used as a supplemental imaging for when you are going through, let's say you do have a palpable area, or there is a painful area that's new to you and you are a cancer survivor. A lot of times the doctor or the surgeon will order a diagnostic mammogram, like Dr. Baxter explained earlier. And if there is an area that we feel we can find an ultrasound where we feel it may need a biopsy, that we will advocate for that.
And that's exactly right. Ultrasound is an extremely useful tool as a focused ultrasound. An area that someone feels, an area that we see on the mammogram, an area that someone's concerned about, to look at that specific area and try to figure out what's going on. It is not a great test for screening the whole breast. It finds, it misses way too many things out of context. You can just scan right past it, not knowing what's there. And on the flip side, it finds way too many normal structures that look like something. If you're just scanning out of context, everything looks like a cancer in the breast. It does. And that's, in that study that I showed where the MRI found so many more cancers than the ultrasound did, they looked at biopsies that were recommended from the different modalities. ultrasound, 95% of the biopsies that were recommended for things they saw on ultrasound were not cancer. And so that's why it's not,
Exactly.
particularly since we have a much, much better test in MRI if you need a supplement.
Did we already talk about the new paddles on 3D, on the HD 3D?
No, we didn't. That's a good point. So yes, that's another one of the benefits. The new machines that we have, in addition to having the high definition, the with the 3D, with the it's a faster compression time, since we're not doing the 2D plus the 3D anymore. It's faster, but there are actually new paddles with them that are curved to sort of mimic the shape of a woman's body. And people are reporting, I've had patients say, and certainly the studies they've done, that it is more comfortable. It's still, unfortunately, we still have to compress with mammograms. That's the way that we get good pictures. And it's the way that, that helps to cut down on the overlap of things in certain parts of the breast with other parts of the breast. It also cuts down on the radiation dose because the x-rays are going through a thinner layer of tissue. So there are reasons we do it. It's nobody's favorite, but yeah, these new paddles, people are finding that they like them.
I think
I had my mammogram this year. I'm waiting to get my mammogram this year and see if it's really true.
Let me know. I mean, I went through a 3D I didn't do the HD or these new paddles, but I went through the 3D mammogram, and it is, in general, it was a quick process. And I try to emphasize that when I have my patients who are a little apprehensive about going through the paddles, they're just worried about the tension, the squeezing, the pain. I think a lot of it is just educating and, prepping them, and they really appreciate that, the education. I think we have one of our pathology counterparts online. I don't know, Emily, if you still see him. Is Dr. Hunter Johnson still on?
Hey, can you hear me, Karen?
Hey, so we've had several patients ask, I'm happy to answer it, but it's nice to have you on. Well, regarding the wait time after biopsies, and, why is it so important to wait, and what's going on there? I guess it's just, we don't know what's going on. Why is there wait time? And, I wanted to preface that with, we have highly, we have breast trained pathologists who are looking at our patients' biopsy specimens. And Dr. Hunter Johnson is one of them. And I wondered if you could elaborate on, the positives to this.
Yeah, sure. So yeah, I'm Hunter Johnson. I'm one of the breast pathologists here. We do quite a bit of breast pathology here. And I'll tell you, this is a topic that could easily be multiple discussions.
I know.
And I know when, it can easily get technical. But the best way to describe it is there's many steps in this process of taking the tissue, from your breast all the way to, getting a hormone receptor results. And sorry, somebody keeps trying to call me, of course. And so, once you get that biopsy taken at the time, with the radiologist at the time of biopsy, it's got to be processed. And what I mean by that is we want to take that from that piece of tissue to something we can make into a slide, which we can then look at with a microscope and use that to make that diagnosis. And so that is a process that usually takes at least 24 hours, sometimes maybe 36 hours to do. It's got to be sitting in formaldehyde or formalin that we use, for a certain amount of time in order to get, as we call it, fixed appropriately. And if all that's done appropriately, you take a piece of tissue, which left on its own would, of course, degrade very quickly, like any matter. We end up putting it in formalin and in wax, and then it can last a very long time. I mean, we usually keep blocks like that for 10 years, but I've done tests on blocks, older than I am, but so they can last a very long time. And then at that point, we'll get the slides, make a diagnosis, and that process itself can also take a day or two, because frequently, some specific cancers and findings are very obvious, and we can say, oh yeah, I can look at it in 1 minute and say, I know what you've got. I can make that diagnosis, send it out, and we can get the reports back to them in a day. Sometimes they can be very challenging, or they have very, atypical findings and things that are sort of in a gray zone sort of nature. Those sort of things, we might want to get additional, what we call stains prepared. to look at the tissue in different ways. We may want to show them to other pathologists, or even send it off for a consult to some, one of the heads of the field. So that can all take a little more time. I feel like generally a couple days in, we probably have a result 90% of the time. And then, the other thing you end up waiting for, I think, that we hear from sometimes are the receptors. So we're talking about the hormone receptors, the ER, the PR, HER2 do, and also it's called Ki-67, which is a mitotic index. Those take a little more time, and usually I would say 3 to 5 days probably. And the reason is we send that material out to a reference laboratory for testing. The reason we do that is because these tests are very regulated, and they have to run under extremely tight, quality controls, and it's very challenging to keep everything in the rigorous level of control required. And of course, that's a big deal, because if we say, okay, you have, you're HER2 positive, well, you want that to be reproducible, and you want what I'm calling a HER2 positive to be a HER2 positive at a different institution at a different point in time, and et cetera. So that's all going to be very tightly controlled, and it's easier generally for laboratories that do very large volumes of these testing to do it, versus trying to maintain their own individual QA/QC on it. So all that put together is those multiple steps can take a few days. Usually I would say 2 to 3 days, you probably get your diagnosis. And then if it's cancer, you probably have another 3 or 4 days until you get your receptors back. That's the process it takes. And I understand, we understand there's somebody on the other end of that, and they're obviously waiting every day, and that can be very frustrating. And, we obviously get calls about that sometimes if there are specific issues going on, but that is the process. Suffice it to say, it is a long and somewhat complicating process. That's to your benefit. I know it's frustrating, but that's to your benefit, because we're, at every step, everything is being very tightly controlled and regulated, so you can get the most accurate result. And when we give you those numbers, you can trust that they have, value, and they're not, they're made under very specific conditions.
Yeah, thank you, Dr. Justin. And to his defense, these receptors are very important. So we value that, while there is some time that's taken into finalizing these receptors, like you said, 3 or 4 days, usually we're seeing these patients back after the biopsy. Once the diagnosis has been made, within 2-3 days, we discuss and give them a general overview. We discuss with them, we keep talking about these receptors. I want you to remember, a cancer cell, we have hands and arms. What do? We feed ourselves so we can grow. So these cancer cells have hands and arms, and they're called receptors. And the food for them is typically either these hormones, 70-75% of the time, the estrogen, progesterone, or the HER2 protein 20 to 25% of the time, which is a protein or a growth factor. Or we have the most aggressive kind, which we typically see in our BRCA1 or African American, Latinos patients that present as triple negative, which there's something extremely inherently aggressive in these cancers that doesn't feed off of the hormone or the growth factor. So a lot of times this information that Dr. Johnson and his colleagues are trying to get for our patients, it does factor into surgical planning. Some patients may need chemo up front, some patients may not. So it is a team effort, we recognize the waiting game. We recognize what that must feel like. But I think a lot of this, if we can talk to you about the diagnosis, have a preliminary plan, and then, have different pathways. If this comes back positive, this comes back negative, this is our next steps. I think the feedback we get from our patients is they appreciate that process. Thank you, Dr. Johnson.
My pleasure.
I think, Emily, I'm not sure if there's anything that I've unanswered.
We have gone over, and I am so grateful for both of you giving extra time to this program. We have a lot of questions in the chat box, and I'm sorry we're not going to be able to get to all of those. But thank you, everyone, for submitting those questions. That was a wonderful discussion. And thank you, Dr. Johnson, for your input. That was great to hear from a patient's perspective what's going on behind the scenes with pathology. I just want to close by giving you both an opportunity to make any closing comments. Dr. Baxter, I'll start with you.
Oh gosh, I guess the one thing that I realized that we had talked about before that I wanted to elaborate on a teeny bit more is about the safety of getting your mammogram during COVID. Um, there, we've taken precautions at all of our facilities throughout the Northside system. We've spread out the appointments, we've made the waiting rooms, the exam rooms, everything's safe. Everything is being cleaned before, during, after, all the time. So I really think that people hopefully can feel comfortable about coming in and getting their checkups because it is so important to do so. But definitely the environment should be safe.
Thanks, Dr. Baxter. We, just to piggyback off of that, in our clinic, we are doing the same. As you can tell in this field, it's hard to do virtual visits, but, to make sure the patients feel comfortable, I do offer that. We do keep our appointments spaced out. We don't have too many patients in our waiting room. And in fact, right now it's been pretty good flow. Once a patient comes into the waiting room, we kind of get them checked in and bring them right back into the clinic area. Even the flow between the front waiting area into the actual clinic, where you're seeing our nurse and you're getting your vitals and your intake done, there isn't a congregation of nurses or other staff in that area. It's usually you and the nurse, and the providers are in their offices to minimize exposure and mitigate that exposure to COVID. And then once you're brought back to your room, please note that the room has been properly sanitized prior to your visit, and it will also be properly sanitized after your visit. And so far, we are appreciative that a lot of our patients are adhering to mask guidelines. And everybody's getting their temperature checked. So we are adhering to guidelines, and make sure everyone's safe.
Thank you so much to both of you. That was a wonderful program. Thank you for everyone who attended. Again, I just want to remind you to visit our website, cscatlanta.org, for more support. Cancer support programs that we offer. This program today has been recorded and will be posted on our website for you to review once we have that edited and ready to go. So I invite you to check it out again. Also, I posted a link to that clinical trial they were talking about earlier, and I think some people said they weren't able to view that. If you're interested in that, email me at emily@cscatlanta.org, and I will send that your way if you weren't able to pull that from the chat box. All right, ladies, thank you so much for taking time and going over time answering these questions. I really appreciate it.
Thank you.
Great. Thank you so much for having me.
Have a good day.
All right, everyone take care. Have a great rest of your day. Bye-bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org. Or follow us on Facebook. We'll be sharing additional information on upcoming programs.